right, everyone. Welcome. And today I have an interview with Dr. Robert Rafa. And just by way of introduction, Dr. Rafa has devoted his professional career to receptor pharmacology and understanding the balance between therapeutic utility and side effects of drugs. He recently retired as Professor Emeritus from Temple University School of Pharmacy in Philadelphia, where he taught for 20 years. He is currently adjunct professor at the University of Arizona. Dr. Rafa received more than $3 million in research funding from the National Institutes of Health and other sources. He has published over 350 papers and is the co-author or editor of several books and is a co-editor of the Journal of Clinical Pharmacy and Therapeutics. He is a past president of the Mid-Atlantic Pharmacology Society, and he lectures and consults worldwide. So, welcome, Dr. Rafa. Thank you for joining us.
Well, thank you, Jocelyn. It's great to see you again. My pleasure to be here, and hello to your audience.
All right. Yeah, and I am excited to have you here. Bob and I met at the International Benzodiazepine Symposium, which I've mentioned a few times previously. And yours was really the presentation where I was just like, oh my gosh, this makes sense now. Like all these things that I've been trying to tell people forever, like make sense now, because your presentation and what you're going to share with my viewers today really explains why this syndrome is so bad, why it's so strange and all over the place, and it just seems so like inexplicable. But when you explain it, I think it'll really help a lot of people. They'll have that aha moment too. And so I'm just really so glad that you were able to do this.
Well, Jocelyn, it worked the other way because I'm a basic scientist, and as I'll talk about in the little presentation shortly, we thought we knew all about the benzodiazepines, and I taught it I don't know how many years, and I'll explain why that wasn't wrong, but it turns out that was only part of the picture. And it really wasn't until meeting the patients who said, there's more to these drugs than you're used to thinking about and talking about. And there was a real an aha moment for us presenters as well, because the gist of the presentation today is we've had a certain perspective of benzodiazepines. And I think what we learned from the patients is we need to consider a different perspective that if it were any other drug category, we would do automatically. But for some reason, I think because these drugs go back so many years now and we know so much about the details, we've lost track of what's going on at the patient level. So it was a fantastic meeting, a stimulus for many good things that have happened subsequently.
I agree. And was that symposium really the first time or the jumping off point for you to really take an interest in benzodiazepine syndrome and to focus your considerable talents on this?
Yes, absolutely. There's no question about it, because when I was asked to talk at the symposium, I was quite frankly, I thought they had the wrong person, because my background is in analgesics, primarily opioid analgesics. And on the way to the meeting, so were a lot of the other people. And as it turned out, we were asked to be there because of the connection between opioids and withdrawal, of course. So there was an analogy at least we could draw on. And, we were all stunned at how little is really known about the withdrawal from benzodiazepines, and how we have been zeroed in on just one aspect of it. And as I'm going to point out in a while, the surprising isn't a strong enough word, lack of knowledge uh, about these drugs beyond, I'll say, 4 weeks. Everybody has a different duration. But as I'm going to show, we know in exquisite detail certain aspects of these drugs, and we know virtually zero about other aspects. And I'll just give you a quick example. I wanted to make a simple table comparing different benzodiazepines and the Z drugs. And of course, I did what every basic pharmacologist does. I was looking at the activity at various receptors because we know they bind to benzodiazepine receptors and GABA A, et cetera, which I'll show. That explains its activity and use for anxiety, but this is what we do. We look at what other receptors or enzymes does the drug interact with as a clue to what the adverse effects might be, what withdrawal might look like, et cetera. I mean, this is pharmacology, not only 101, but day one of pharmacology 101. Zero information available for two reasons. One, some of these drugs are so old that these assays were not available. For the newer drugs, it's as if it doesn't matter to them because they're saying, here's the activity at the benzodiazepine receptor. That information is available, but then they stop. Mm-hmm. They don't do what would be absolutely typical in any other area, do a broad receptor screen. No kidding, over 100 receptors, enzymes, ion channels. You just do it automatically. There are companies set up to do it. You know, you check the box, you send it out, and you get all the information back. I could not find any of that information. So what do we know? We know they work with the benzodiazepine receptor, and that's it. And I'm just going to give you a little tickle of some activity that we came across that I think is a real eye-opener. And maybe the bottom line is here how little we know, which is, I think it's going to resonate, with your audience.
Yeah, well, let's get right into it then. So show us.
All right. All right. So what I thought I would do today is, not everybody is going to be interested in the details of the science as much as I am, but I want to sprinkle that in just to show what we do know and what we don't know. But my real goal today is to suggest, and I haven't heard anybody else suggest it other than I have given some local presentations. It's a new perspective. And in other words, what I mean is a new way of looking at the pharmacology of benzodiazepines and the Z drugs. And of course, your audience knows that they go hand in hand. I'm not going to talk about the individual differences among the drugs, but I am going to talk about them together.
Right.
So what I would like to do is describe what I am now going to call the traditional perspective. And this is what I taught for 20 years. Every pharmacologist I know teaches the exact same way. We could interchange our slides. And that is, we think about the benzodiazepines and the Z drugs. How do they treat anxiety? That's what we do as pharmacologists. It's what it's good for. We want to understand in more and more detail why that is. But number two here is what I want to do today, and that is introduce just a proposal as a new way of looking at benzodiazepines and Z drugs. Number one looks at the receptor level. Number two, this is novel, looks at the patient level. And I think when you do that, you suddenly see really, again, as you said, the aha moment, you see this in a whole different light. And then I know because you're very interested in the protracted withdrawal. I want to discuss that a little bit, and then a little bit about some research that's being funded by the Alliance, which I'll mention later, right here at the University of Arizona. So this is, I think we would all recognize this as the traditional view, and that is from the point of view of anxiety. That's the starting point, that's the target. And, you know, in 1843, this is all we knew about it, right? You try to draw some sort of picture of somebody who had what you thought was the problem, and that was it. And then, and this is not trivial to say that it was an eye-opener to realize that anxiety was related to a specific organ and therefore might have a biochemical, physiological underpinning. Prior to that, you know, brain disorders, if you want to call them that, were mysterious. Matter of fact, they weren't even called brain disorders in the beginning. They were, you know, mental, whatever that was supposed to imply. And there were certainly hormonal explanations, blood, et cetera, et cetera. So this was actually a big advance, even though it seems trivial now. 1977, huge progress was made. That was the discovery of the GABA-A type of receptor. GABA is a neurotransmitter in the brain, actually one of 4 of the major controlling neurochemicals in the brain. There are 2 that are sort of excitatory, that keeps us awake, and there are 2 that are inhibitory, which keep us from getting seizures. And as long as they're in balance, everything is great. When they become out of balance, then there's a problem. Well, they discovered that anxiety was a slight imbalance in the functioning of GABA, a neurotransmitter, and GABA works at the GABA-A receptor, and that was related to anxiety. So this was extraordinarily exciting, and it wasn't long after that people designed drugs that interacted with that receptor. Once you know the target, getting the drug turns out to be very, very simple. And the benzodiazepines turned out to be, historically, in the trajectory of medications, really the best. Now, just to give you a flavor of how much we know about the interaction with benzodiazepines and anxiety, on the left is sort of a side view of the GABA-A receptor. In the middle, I wonder if I can, maybe you could see the arrow. In the middle there, oops, I'm having a, there you go. In the middle there is showing some detail of the GABA-A receptor, involves ion channels. Here's another view, and the benzodiazepines bind at a certain site. GABA binds over here and here, benzodiazepines here. I mean, it's amazing in what detail this is known. You can go even further and you say, well, how does this relate to anxiety? On the left there, the blue line under the arrow here shows what happens when you have an excitatory stimulus. You get a neuron that fires. Benzodiazepines inhibit that in a very neat little way. They don't in any way block the neuron, that would be bad. But what they do is they sort of set the tone down a little bit. So the next time there's the exact same excitatory stimulus, you don't get quite the firing you used to. So you're still alert, you can function. It's just that in excess activity, you don't respond with quite the same excess result. And this is what I was talking about earlier. GABA is in equilibrium with glutamate. Wonderful balance. So when it works well, everything's perfect. When there's a little bit of imbalance, then the system needs to be toned down or modulated. and that's what the benzodiazepines do. So I'm going to have the good, the bad, and the ugly of benzodiazepines. This is still from the perspective of anxiety. So before the benzodiazepines, the anxiety was just some nebulous clinical situation. As you know, it was considered psychological, it was a neurosis, minor tranquilizers were used, just not very helpful terminology. Barbiturates were used and other non-specific agents. They were really not good at all for many, many reasons. So the benzodiazepines, I think I want to put them in the perspective historically on really what an advance they were. Now, we're going to quickly say, you know, they're certainly not perfect, and they do cause potential for problems. But at least at the time, it was eye-opening to say, well, maybe it is something that's going on within a brain. And that's exciting to us because that means chemistry, chemicals, and we can do something about it. So it's equivalent to say diabetes is related to insulin, and boom, that gives us a target, something that we can work on. So it provided the hope for the first time of a target, and it stimulated basic science. And the benzodiazepines were relatively selective. And if we stick with the brain, they are selective for anxiety. They don't do other things. So that put them heads and shoulders above what was available to the time. And they were far safer when given alone. Now, when I say safer, this only meant in terms of deaths.
But you know, and from my understanding, benzodiazepines really, what they do is just kind of dampen the central nervous system. Is that a correct way of putting it?
Not really. That's definitely what ethanol and the barbiturates did. Mm-hmm. So that was the original excitement about the benzodiazepines. But I'm going to come back to what you're saying.
Okay.
Are we going to talk about 4 weeks? Or are we going to talk about longer? And I think that's the great divide from what the initial excitement was to what you're talking about happening.
Okay. All right.
So you see, this only, if you do it right, the right dose, the right drug for the right amount of time, it doesn't tone down the entire brain. It just modulates or attenuates the excess activity. So far, that was all good. And I remember teaching from day one the following two things. Number one, I guess three things. Anxiety is a protective mechanism in the body, right? I mean, we got to go back to the animals, and they need to have an anxious response if there's some sound in the bush, because it could be a life-threatening challenge. So you don't want to eliminate anxiety completely. That's where it gets tricky, and that's where these drugs are never ideal. Sort of like the opioids. You know, if it was simply a matter of getting rid of all pain, that would be simple. But you can't, and that's why these drugs always have problems associated with them, because it's so tricky. The other thing we used to teach was that, you know, there may be a good reason for being anxious, and maybe you need to address that, right?
Right.
But you may need help, particularly in the first couple of weeks, and therefore these drugs were appropriate. But then this became more into the beyond 4 weeks. It was more in the realm of, you know, other types of therapy. What in the old days was called psychiatric therapy. Now we would say more like behavior therapy, cognitive therapy, etc. And that, you know, you wanted to address the anxiety Maybe you have an anxiety of flying, right? I don't think the answer should be benzodiazepines for the rest of your life every time you get on an airplane. There are other better ways, but maybe something came up, you have to go to a funeral or something across country, you have to get in the airplane, you don't have time for the other therapy. So along with the anti-anxiety effect, there was a whole host of adverse effects. But this is really true of any drug. And as long as the therapeutic effect is good and working, most of these are acceptable. They're not so serious that, if it's working for its intended purpose, then that's okay. The only thing, though, I think already there should have been a clue here. Why so diverse? So if I were to list, again, as a comparison, the adverse effects of opioids, you would have constipation, respiratory depression, effect on the endocrine system, etc. But these are all very understandable from the basic pharmacology of the opioids, and even withdrawal. It is totally predictable. These are not for anxiety. And I think we sort of, ignored these, or ignored the message. We said, well, you know what, you may get some of these things, but it's not going to be serious, certainly not life-threatening. But I think looking back, we should have noticed it. Now, of course, there are some pretty serious effects of the benzodiazepine use that we're all very familiar with. But this found very interesting. Dr. Steve Wright, who I know you've interviewed, he's the first to point this out, that there were publications talking about withdrawal associated with the benzodiazepines as early as 1963, and just consistent even with Valium, etc. And it was claimed, and I remember always hearing and reiterating, I'm sorry to say, since it wasn't my specialty, that there was really no withdrawal from benzodiazepines. And maybe, a couple of complainers said that there was, but we could discount it. So that's the bad. Now the bad continues in the promotion of these drugs. Now look at this. This was the claim not that long ago that 28% of the population suffers from anxiety. Now that is just an overestimate by anybody's definition, but this is what was being advertised. You have to excuse me for this picture. It's not mine.
It's pretty bad.
Yeah. And if I could interpret that, I think she's thinking, I'm going to strangle this photographer. You can't set her free. Oh my gosh, can you imagine? But you can help her deal with this situation. That's the way these drugs are advertised. And look at this, sales continue to go up. Mm-hmm. And I don't know if you could see this. This is 2016. Nobody will admit they're prescribing benzodiazepines. Yeah, well, here are the data.
Right? Yeah.
And they are.
Yeah.
Now, here's, I'm going to say, this is the ugly. This was now a famous, I should say, infamous study in which, I'm not going to go into detail, but this is in humans, and down is better. So the red line is Xanax, and obviously compared to placebo in blue, Xanax is much better. Mm-hmm. But guess what? This is what they published up to here. If you follow what actually happened, Xanax was much worse, all sorts of weird things happening up here above baseline. I believe they were sued and there was a lot of consequences to this, but that's what got out there. So the prescriptions extended way beyond not only the label, but the existing data. There's really hardly any data at all beyond 4 weeks that I've been able to find.
All right. But that's what
So
doctors knew. They knew, oh, this works fantastic for anxiety.
it
But
worked fantastic in 4 weeks. So what a success. I mean, these patients had nothing before that. And, especially nowadays, the patient comes in and they say, okay, let's talk about your diabetes, your hypertension, your high cholesterol. Oh, by the way, how's your anxiety? How's your anxiolytic working? Fine, good. One less thing we're going to talk about. We'll talk maybe next time.
yeah.
So healthcare providers, now this is an exaggeration, but I claim that they're flying a little bit blind beyond those studies. There's really not good accepted methodology for guidelines, which is really surprising. And I know Dr. Wright has been looking very hard for what guidelines they're really. So, in some ways, the clinicians cannot be faulted. What they have been taught, partly by me, that these drugs have an excellent mechanism. They're targeted, and in the short term, they're very effective, quite safe, almost impossible to die of overdose alone on them. And, the clinicians are saying, well, what do I got to lose?
Right. Well, but as we know, death isn't isn't necessarily the worst thing that can always happen with a drug. And
Exactly.
I'd also like to push back on just this one idea. And again, tell me if I'm off, because the thing that I love about interviewing you and others is that I'm definitely not the smartest person in the room when I interview you guys, which is great because I know that I'm in good company.
There must be somebody behind me that I don't know about here.
No, it's like I know I'm with the right people when I'm not the smartest person in the room. But this idea that you're treating anxiety per se, I mean, you showed us how anxiety, like people, you have that excitatory response, obviously, but it's not necessarily that we're treating the cause, because from what I understand, anxiety isn't necessarily like a GABA deficiency,
You're exactly right. And that's why we always taught just to get you through until you could address the real issue.
Yeah, it's a symptom we're treating, but not a cause, right?
Absolutely. And I think what happened is what you're saying is that, geez, it seems to be working. And we forgot about, well, we have to treat the underlying cause here. And, these drugs are safe, no problem. Let's just continue to treat the symptom. It's almost like you give a pain reliever and
Right.
you say, wow, it's working. And you keep giving the pain reliever and you don't look for the underlying tissue damage. I think you're exactly right about that. And that's what I want to come back to. Oh, actually, perfect timing, Justin. This is
good.
A good transition. So as I was preparing for the presentation in Bend, I said, well, maybe I'll present something a little new, if there is anything. I don't think there is. And what I came across, I only found sort of because of the wonders of the internet, because what I found was called by something else. And none of my colleagues had heard of this other target for benzodiazepines, which I'll get into. And so it was all under the radar. That field didn't realize it would be of interest to the central nervous system people and vice versa. So then it got me thinking about the whole thing now. Instead of starting with the patient and then going and looking at the receptor and then the drug, what if we said, let's start with the drug. We're giving a drug to a person, right? And the drug goes into the brain, interacts with the receptor, and reduces anxiety, certainly in the short term. And then I thought, well, there's a lot below the head here. the drug goes to the rest of the body.
Exactly.
Nobody ever talks about that. I mean, why would we? Because we get our grants to study this. We don't get our grants to study this. Clinicians are not thinking about this because they're looking at this. How do you feel? Oh, my anxiety is less. Woohoo! You know, success. Let's just keep doing it. So what about other pharmacology? And in our circles, we would call that, what are the off-target effects? The target effect is treating anxiety. But what's known about the off-target effects? Well, here is where it becomes less and less clear, almost to the point where it disappears. So this is the way a pharmacologist would look at this, but I want to explain how I interpret this into the clinical situation for the patient.
Okay.
Receptor binding profile. This is in the test tube. Benzodiazepine receptor. Lots of data. Other receptors. Nothing. Can't find anything. So it's as if we're, what's the right word? Just focused on one thing and we're ignoring everything else. So I said, okay, let me just search the literature and see what else benzodiazepines do. Well, did you know that benzodiazepines potentiate the adenosine A2A receptor-mediated action by inhibiting the nucleotide reuptake transporter, the primary mechanism of adenosine degradation?
Oh, okay. Well, now it's
well,
now it all
I
makes
didn't
sense.
know that. And what does it mean? I have no idea. And no pharmacologist could jump from here to what's happening into a person, let alone the short-term effects, or not only the short-term effects, but let alone the long-term effects. So I don't know if that means anything at all clinically, but I think that's the theme here. I don't know, and I've looked real hard. Nobody knows. The clinicians don't know, the researchers don't know, the patients don't know, the regulatory agencies don't know. How are you going to put a label on a drug when you don't even, number one, 99% of the world doesn't know this, and 100% doesn't know what it means. It also modulates the alpha-1 adrenergic receptor. Now, we can forget about the rest. Now, I find this interesting because we do know the connection of this with the body, and that would have to do with blood vessels and maybe blood pressure and certainly effects in the brain. So I can't jump from this to say what's going on in the patient, but all I could say is I think back to the Benz symposium and I go, oh, you know, all those symptoms that were a little nebulous and different for everybody, maybe there's at least one little connection here.
Yeah, I mean, blood pressure, low blood pressure is so common. It's like,
there you go.
It's just a common thing. And then people who have POTS where they stand up and then they pass out, or, you know, just crazy things like that. It's so common. But
I didn't know that, but there's your connection right there. Alpha-1, adrenoceptors, and blood pressure is a well-known connection, but just not in this arena. So now we have we can begin to draw a picture like this. When you think of giving benzodiazepines or the Z drugs to a person, this is what's going into the brain, anxiolytic effect. What about all these others? Yeah, I showed you all the gory detail of these, question mark on these. So let's now look at what patients tell us from the protracted withdrawal. And I'm saying that's kind of curious. And this is, by the way, from repairing the benzo blunder, which I'm sure your audience is very familiar with. So this is a list of some of the things that she described in there.
Yeah, well, and just for anybody who doesn't know, repairing the benzo blunder is Marjorie's book, correct?
Yep.
And you can, I think you can find that on Moonglade press, but she was really the main force behind the International Benzodiazepine Symposium, and she had written this book kind of for that event in a sense.
Yeah. Yeah. So I forget if she had a table or I just put it together. Either way, so this is what would happen, say, in withdrawal. So anxiety, okay. I mean, that would be expected. The opposite, panic attacks would be expected. Or the opposite would be expected in withdrawal. Now, after long-term use of drugs, it's not as easy to predict, but I would say this is somehow related to the GABA A receptor, benzodiazepine receptor, no problem. Tremors, maybe I could come up with something. Tinnitus, insomnia, headaches, in black here. I would say, I don't know if I could make a direct connection, but I would say you could convince me that that's related to the benzodiazepine receptor. Anything in red, no way.
Mm-hmm.
Why would there be constant flu symptoms? There is no known connection. Fatigue, no way. Weakness, no way. Nausea, sweating, loss of appetite, hair loss, anhedonia, and GI effects. In humans, it's well known that GI effects like constipation and diarrhea is totally peripheral, not related in any way to the brain. And so, this is, to me, this is a big question mark. Like, if you gave this to a pharmacologist, they would not say, oh, obviously that's a drug that interacts with the benzodiazepine receptor. They would come up with multiple sites of action and mechanisms of actions. So now, instead of being curious, now it's getting even curiouser. And then I'm really happy and sort of proud I came upon this, because I'll tell you, if there's a picture that speaks 1,000 words, it's this one. And I came upon something that's called peripheral benzodiazepine receptors. Now, it goes by other names. That's why not everybody knows about it. These are benzodiazepine receptors that are located in other parts of the body other than the brain. And here's the other name. It's quite a mouthful, and that's why I don't use that name. So here's a typical study that would be done. Now, this happens to be done in a way that highlights these receptors. And the way these are done is when you see a lighter color, that means there are more of these receptors. I have never seen a scan that lights everything up like this. Usually we're looking with the little, eyepiece to try to find. It's more like this, oh, I think I see something there.
So this is like somebody who's taken benzodiazepine.
Yep. And look at this. What's the lung? Why is the lung lighting up? The liver, the kidney, the spleen. Oh, I get it. Every organ.
Right.
Every organ. Now, what the heck is going on there? So, I want to come back to that. So there are changes during long-term use of any drug, and that can affect withdrawal. We've always known about the central benzodiazepine receptor, but now there's this peripheral one, and based on that picture, we got to learn more about that, because there are more of them in the periphery than in the brain. Mm-hmm. So there are other receptors, enzymes, that just do a Google search, you find these strange connections. Jocelyn, I think the first time I met you, you asked me about receptor up and down regulation. And that's when I first knew that you all knew and had been thinking a lot about this. Hysteresis. This is the idea from engineering that sort of like a rubber band, when you pull a rubber band and then you release it, it goes back to its original shape. You do that a couple times though, and what happens? you expand it, and it doesn't quite go back to the way it did before. And there's evidence that this happens in physiological systems. So clinically, that means the first time you take a benzodiazepine, certain effect. Then you return, you take another dose, same thing. 3 weeks, 4 weeks, maybe you don't return to the same starting level. This is something there's one reference in the literature that says this might happen, but this is test tube data. I think this is something that needs exploration. And I think this has to be going on after months or a year of therapy with any drug, certainly the benzodiazepines.
Oh, yeah, definitely with many drugs, but
Yep.
in particular with benzodiazepines, it sounds like that would be a valid explanation for kindling phenomenon.
Yep. Absolutely.
Right? Yeah, where people sort of, they have a certain sensitivity and then they take it and then it just doesn't help, and then they take more and then it doesn't help, and then all of a sudden they have like no sensitivity to the drug in a sense, but their central nervous systems are completely out of whack, because of the medication. So.
And what makes it so hard to study, Jocelyn, is that we're all thinking about the body's response to the first dose. And we're trying to understand what's happening weeks, months, years later based on that. And this is a brand new concept. I mean, to pharmacologists, not to engineers. The idea is the system is changing, and you cannot explain what's happening with even a well-known drug after that long a time period based on, and all our experiments are on the first day.
Yeah.
Right?
Right.
And that's not even getting into these other issues, long-term changes due to effects of the drugs on protein synthesis, epigenetic effects, et cetera. And that's all going on. So that's what I said here. I said, oh my goodness, maybe the patients are right, because these things are more associated with peripheral effects, maybe the peripheral benzodiazepine receptor. So that's what I'm saying. In terms of pharmacology of the benzodiazepines, if you think about what's going on to the whole body, we're at day one.
Yeah.
We have to study this as if we just came upon it. Now, just quickly say research. I want to give a shout out here to the Alliance for Benzodiazepine Best Practices. And Carrie Silvernail is just a wonderful, as you are, Jocelyn, spokesperson for this area. And you give credibility to the patients.
Thank you.
And Bernie, Carrie's husband, was interviewed by you. Very nice. And Bernie is sponsoring through the Alliance basic science research specifically into the peripheral benzodiazepine receptor. And so Dr. Vanderwall, who's the chair of the pharmacology department at the medical school there, is going to be looking at these things, and he's going to try, he's looking at sort of two levels. One is the basic science level, but then he's going to relate that to a model of benzodiazepine effects, and specifically look at withdrawal and try to look at the relationship between those peripheral benzodiazepine receptors and the clinical situation. So again, I think the message here is not that he or anybody else is going to get the definitive answer, but it's going to highlight the lack of knowledge that we have, and hopefully that will stimulate others to begin to look at this, because this is a brand new field. It should be extraordinarily exciting to the basic scientists as much as the clinicians and the patients and really everyone. I mean, it's stunning that the drugs that are so old, that this is, so little is known, and how exciting it would be to learn about it, but more importantly, how it might help patients in understanding what's been going on.
Yeah, I'm excited for that, because I think having any sort of research on this will help to validate all of the patients' who are saying these things, but nobody believes them.
Right.
And also, I just think that's interesting that you're saying this is exciting. I hadn't thought of that before, because not only is this almost like looking at a new drug in some ways, but you also strangely have an overabundance of information from decades and decades of anecdotal
Right.
evidence, clinical kind of experience with these drugs. So it's this strange place, I would think, to be as a scientist.
Well, I'll tell you the other thing I like about the basic research is, of course, ultimately, I think we would all like the FDA to say something about this.
Oh yeah, wouldn't we?
It's a big debate. I mean, that's another aspect of what we're doing. We're having panel discussions with people who are expert and interacting with the FDA. And there've been a lot of suggestions, related to scheduling, labeling, et cetera. It's a big story. And some of the best strategies aren't the most obvious ones. But nevertheless, I think, if you're going to go in front of the FDA, you got to have new data.
Right.
You can't say, well, this person's having problem, because I don't know, I guess we don't know the actual numbers, but it's not as if every person on a benzodiazepine has problems. It's not as if every person is on them too long. It's not that even every person who withdraws has all those problems. So we're going to have data, and I think the only way to get FDA's attention is to have new scientific evidence that maybe something's going on. We're not going to have the answer, but I think we could say, you know what, you've forgotten from here on down, and you need to address that in your label.
Right.
So I think we would all agree on this. Many patients are prescribed benzodiazepines for certainly much longer than the FDA labels, and certainly the clinical data support. Now, are there some patients who do well long-term? I'll leave that to the clinicians. The evidence base for the adverse effects, and particularly of withdrawal, is really, I don't want to say it's non-existent, but close to it. And here's what I think I learned from going to that symposium, and certainly in the couple of years since, is that, what the patients have been saying about the prolonged withdrawal symptoms and the fact that they're different, I think could be explained by these off-target sites, including the peripheral benzodiazepine receptor. And I should mention in closing that the reason why the whole body in the periphery lights up with the benzodiazepine receptors, the peripheral, is, guess where they are? And why does everything light up? They are on mitochondria, the cell's energy source, and on immune cells. Mm-hmm. So now when you go back and you say, well, what are the patients reporting? Tiredness, alterations of sleep, maybe those continuous flu-like symptoms. You say, oh my gosh, energy and immune system, and it would look different for every single patient, right?
Yeah. So we're talking about the production of ATP for any kind of energy at all.
Absolutely. So there might be two patients that say, you know what, I don't notice the energy difference. Other patients might say, oh my gosh, that's the biggest thing I notice. I haven't really thought about if I get colds or flu more often than I did before. Mm-hmm. Or you know what, my mentation, I hadn't really noticed it, versus someone who says, wow, that's the biggest thing. And it strikes me we have an analogy, and that is with lupus. There are certain symptoms of lupus. I don't know, I forget how many, 12, something like that. Mm-hmm. So to be diagnosed with lupus, I think you only need 4. We'll have to check on the numbers, but something like that. So it's quite possible that 2 patients meet each other and they both have been diagnosed with lupus. They don't share a single symptom. Mm-hmm. I think that may be something here. So I think the message of that last point is, we may never have 6 symptoms that you'd say, aha, that is, I'm going to diagnose you with prolonged withdrawal symptomatology. And I think we need to be open to that there could be this difference.
Yeah, and when you say prolonged, I think you're probably talking about anybody whose symptoms go beyond 4 weeks, right? Like you're not even talking about.
Oh, well, you know better than me. I mean, weeks, months. I think Marjorie would, maybe you also would say a year or longer.
Mm-hmm.
And I know, in the Ashton manual, she suggests tapering, over 2 years would not be.
But I mean, a lot of these symptoms that you're talking about, I wouldn't even refer to them as withdrawal symptoms. I mean, a lot of people, I know I personally, when I was still on it and I didn't think there was anything wrong going on, I was getting chronic infections that I had never had before. And, of course, no idea that's related to the benzodiazepine till afterwards. And you hear that that's a common symptom among the withdrawal community. So, yeah.
Well, you made a good point, because if the benzos are affecting the immune system while you're taking them, that could be a direct connection while you're taking them, as you're right, not even related to the withdrawal problem.
Yeah, and the symptoms are so odd. A lot of people are like, I'm great on my benzo, and then you start digging in, and you're finding all these little things that are weird or new things they've been diagnosed with, and you're like, I know it sounds crazy, but that could be the benzodiazepine. So just so you know.
Well, it works the other way as well, Jocelyn. There's a patient that we both know who has been having problems with, I believe, her hip. Mm-hmm. And she just reflexly said, well, oh my goodness, I've been suffering with benzos for so long. It's probably related to that.
Right. Well, yeah, because everything is, so you get used to it. Yeah.
She finally got it diagnosed, and it is common run-of-the-mill osteoarthritis.
Yeah. Yeah. So tricky being a patient in this benzo world that we've entered. Well, I really appreciate you sharing all of that information. I know that it's usually you're used to sort of speaking to medical professionals in a more formal setting. And so I appreciate you sharing your information in this way with me and my viewers, because I really think that if you at least have some language or some way of explaining this, maybe that is one person who will have an advocate who will be willing to help them, or one family member or one doctor who will kind of get past their own biases and recognize, hey, you know what, this person really might be severely injured or ill, and right. Believe them and actually help them. So it can make a huge difference.
Good. Well, first of all, I want to thank you. It was a real pleasure for me. And I also, I'll flip it around and saying thank you all for sharing your experiences. I know it wasn't easy and doesn't continue to be easy to go through. And I know it's very difficult to be out front and share your experiences. I'll just say I know it's not easy. So thank you.
Well, thank you too. Thanks for sharing your time with us today. So yeah, I was going to say something that I normally say, but you're in kind of a different position because you're more of the research. You're not really like dealing with patients per se. Right. But if there was anything that you could sort of go back in time and sort of change, what you said to the students and the people that you taught, just kind of in a nutshell, what would you go back and change about that?
I think I would go back to 2 slides. The first slide showing the patient leading to the drug, and then that's what everybody shows. I wish we would have shown the second slide, starts with the drug molecule and goes to the whole body. I think that would have helped a whole lot.
Yeah, that makes a lot of sense. Well, thank you, Bob, for doing this, and I look forward to hearing more about your research and seeing future presentations and everything that you're involved with.
All right, great. Well, hey, stay safe.
Thanks. You too. All right, bye.
Take care.